special medieval value meal. Only at CK Chicken. Get ready to enter an Iron Maiden of flavor.
We've reached the finale of our ischemic heart disease chapter. In our first video, we showed the pathological mechanisms that cause an oxygen supply-demand mismatch and how the cardiac myocyte responds. Then, we followed up with a sketch focusing on coronary artery disease specifically and how it leads to angina and acute coronary syndromes. In this sketch, we're going to finish up our discussion with myocardial infarction. What happens to that tissue when the blood flow stops and necrosis sets in? Will that papillary muscle rupture? Will it cause sudden cardiac death? Is Serial Pharrell still alive? There are sure to be spoilers ahead, so just skip to the next video if you're worried about that kind of thing. Besides that, only one thing is for certain. Ischemia is coming, my friends, and necrosis is coming with it. All right, let's head over to Cardiology Rock, where the prince is celebrating his name day. As you know, every good prince needs a good jester, so this year, he's decided to hold a little contest. He's rounded up all the jesters in the land so that they can perform in front of him, one by one. If he likes you, you're in luck. You'll receive one of the greatest honors in all of jesterdom and be dubbed the prince's personal fool. If he doesn't like you, how does that old saying go? When you play the game of ischemia, you win or you die. See that broken heart stir? That's a recurring sketchy symbol for myocardial infarction, or MI. Instead of myocardial ischemia, which can be reversible as long as blood flow is restored, we've got infarction, which involves irreversible cell damage, cell death, and tissue necrosis. The old school saga of MI presentation is a sweaty, anxious, middle-aged cis dude with crushing substernal chest pain and shortness of breath due to the sudden rupture of an atrial plaque chunk. Yep, that anvil could drop any moment, but it doesn't fall the same in everyone. In fact, a lot of people won't have or won't report chest pain at all. Instead, they'll have one or more of the following: shortness of breath alone, epigastric pain, nausea, vomiting, palpitations, generalized weakness, and or syncope. These are symptoms to watch out for, particularly in cisgender females, elderly patients, and those with diabetes, especially because the lack of chest pain can cause delayed or misdiagnoses. Large, well-designed studies on MI risk in presentation in transgender patients are needed. Pronto. Once infarction sets in, symptoms typically last longer than 30 minutes, and they're not going to be relieved by rest or nitroglycerin. Because of that area of infarcted myocardium, the heart can experience a sudden drop in systolic function. So besides the classic symptoms of chest pain and pressure, we're also going to see a few symptoms related to systolic heart failure, embodied, as usual, by a recurring floppy failing heart balloon. Really just a visual metaphor for how this party is going so far, if you ask me. Now, just like we illustrated at the beginning of the unit, heart failure can manifest in numerous ways. It all depends on whether the left or the right ventricle is failing. Almost half of all MIs are caused by an occlusion of the proximal left anterior descending artery. That's the big first branch of the left coronary artery that runs straight down the front of the heart. Just like that left anterior braid of hair, see? When you think of LAD occlusion, think of lady, as in the lady of cardiology rock herself. We've put the queen on the left side of the throne, whispering into her son's ear, as usual, because the LAD feeds the anterior wall of the left ventricle, the anterior two-thirds of the ventricular septum, and most of the heart apex. That means a large portion of the left ventricle is relying on that LAD for oxygen supply. Knock it out, and you can expect the characteristic symptoms of left heart failure. As fluid backs up into the pulmonary circuit, listen for bibasilar pulmonary crackles on physical exam. That's where the fluid likes to hide out, at the bases. Pulmonary edema also further contributes to dyspnea, as depicted by the uncomfortable breath being expelled by our newbie drink server here. On cardiac exam, you might be able to pick up an S4 heart sound as well. Hear that? It comes right before S1. The infarcted area of myocardium becomes stiff and non-compliant, so each time blood rushes into that left ventricle, it smacks up against that stiff wall, producing an extra heart sound. Just think of a recurring stiff-walled wooden chair here, with the sides designed like the number 4, as in S4. If the infarction is massive enough, involving something like 40% of the left ventricle, the ensuing drop in systolic function will cause cardiogenic shock. That means hypotension and complete cardiovascular collapse. At Sketchy, cardiogenic shock is represented by a heart with a lightning bolt, like the one incorporated into the sigil here. Yeah, this is getting pretty serious. Here's the thing though. When you think of sudden death after an MI, you need to be thinking of arrhythmias. Throughout this course, we'll talk about arrhythmias that originate in the atria or other supraventricular structures, like AFib, A-flutter, Wolff-Parkinson-White. It's the ventricular arrhythmias, however, that you need to really watch out for. Ventricular tachycardia or fibrillation leads to zero cardiac output and sudden cardiac death. See that quivering heart accordion on top of the last contestant? It's meant to evoke an image of one of these fatal ventricular arrhythmias. Significant progress has been made in treating patients who present with acute MI. In-hospital death rates are now below 10%. Sadly, a substantial portion of patients never even make it to the hospital. Approximately 20 to 30% of patients will die within an hour of MI onset, typically from VTAC or VFib causing sudden cardiac death. Alright, all this talk about occluding the left coronary artery system, what about the right? For that, focus your attention on the right side of the throne, where the hand of the king, the right hand, if you will, stands guard. Around 40% of MIs occur because of an occlusion in the proximal right coronary artery. This ends up affecting much of the right ventricle. Coronary arteries don't just supply cardiac myocytes, they supply the pacemaker and the conduction pathways of the heart as well. The right coronary artery is largely responsible for getting blood to the SA and AV nodes, for example. At Sketchy, the SA and AV nodes are represented by cardiac nodes, like the two on the heart shield there. Knock out that right coronary, and you can cause some serious Brady arrhythmias. Let that heart watch, falling to the ground as James realizes what a monster this young prince has become, represent bradycardia caused by SA node dysfunction. Watch out for heart block as well, which is a sign of a dysfunctional AV node. At Sketchy, whenever we mention heart block, it will always be embodied by a recurring heart shield. Just like with the left-sided MI, expect symptoms of heart failure when that right coronary artery gets occluded. The right coronary artery feeds much of the right ventricle, and if the patient has a right dominant coronary circulation, which 90% of people do, the right coronary also feeds the posterior third of the ventricular septum, as well as the posterior left ventricle. In other words, think of that right coronary as feeding the right side of the heart, as well as wrapping all the way to the back. Kind of like how James here is reaching with his right hand, all the way to the back. Wait, what's he doing? He wouldn't, would he? They don't call him the Kingslayer for nothing. Needless to say, when an MI involves the right coronary artery, much of the right ventricle is affected. Expect the characteristic symptoms associated with right heart failure, hence our recurring heart failure balloon at his feet. Boy, this party really died. Jugular venous distension is one of the classic findings in right heart failure. And as usual, it's represented by that big blue distended jug. The lungs are usually clear, as left ventricular systolic function remains relatively intact. When that right-sided stroke volume falls, however, total cardiac output diminishes in spite of a preserved left ventricular systolic function. This can lead to systemic hypotension and, you guessed it, shock. Alright, Before we shift our focus to the gross and microscopic findings seen on histology in the wake of an MI, let's quickly sum up these clinical events occurring around the prints. On the test, when they mention crushing chest pain, ST elevations on ECG, and some lung findings, think of left-sided infarction. If instead they mention sudden chest pressure, nausea maybe, and bradycardia or heart block, they'll probably mention JVD as well. That's right-sided. One last thing. Right-sided infarcts are often detected in the inferior leads of the ECG. That means you'll see ST segment elevation in leads 2, 3, and AVF. Take a close look at that shield there. To the prince's right. You see it? For right-sided occlusion, remember 2, 3, and AVF. They'll throw that in there every time. All right, for the second half of the sketch, we're going to focus on histopathology. As infarction progresses, there's a specific timeline of events that you need to memorize, involving both microscopic and macroscopic tissue changes. It can seem daunting at first, but trust me, after you witness the horrifying torment that these jesters are being put through, you'll never be able to unsee it. We'll start with the first 0 to 4 hours following MI. See the hat we've added to the first gesture? 4 clock dongles, representing 4 hours. We've added a myocardial pattern to his tunic as well, and if you look closely, you'll notice that it's completely normal. Yep, in the first few hours following MI, there are few microscopic or gross changes. It's just the eye of the storm, however. Next, we'll go from 4 hours to 12 hours post-MI. So now we're up to half a day, hence the half-sun mask worn by our next jester. In the 4 to 12 hour window, you should start to see wavy fibers on histology, kind of like those sleeves he's got on, waving around as he stumbles backwards. Not only that, we've incorporated the classic histological findings right on his shirt there. The wavy fibers are the result of dead, non-contractile muscle fibers being pulled by adjacent contractile muscle fibers. At this time, you can also see edema and punctate hemorrhages in the infarcted myocardium. Yeah, unnecessarily grotesque. I agree. Also, you may have noticed that creepy skull-filled dungeon down there. That catacomb necropolis represents all that is coagulation necrosis. He's not quite in there yet, though. Just teetering on the edge. That's because you might see very early signs of coagulation necrosis before 12 hours. After 12 hours, though, that guy's a goner. The full sun mask on our third jester is there to remind you that a full day is passing. We're now looking at a window of 12 to 24 hours post-MI. At this point, coagulation necrosis is frankly visible under the microscope. The cells are dead, they lack nuclei, they just look kinda lifeless, you know? The structural outline of the dead cells is preserved, so what you're left with is just an ornate and undeniably macabre arrangement of pale pink skulls. Note the pattern on his tunic as well. When blood flow returns to the area of infarction, abnormal amounts of intracellular calcium in the irreparably damaged cells causes hypercontraction of the dead myocytes. This is called contraction band necrosis. I mean, just look at him, futilely clinging on for dear life. See those hypercontracted arms? Yet again, we've incorporated the classic histological findings right on his shirt as well. Those linear densities within the myofibrils are the contraction bands. Boy, that escalated quickly. I mean, that really got out of hand fast. Jesters and whatnot, and then what was that? An acropolis? It jumped up a notch, didn't it? I think it's time to send in the neutrophils. Neutrophils are like the first responders of the immune system. They're the first to the scene at the site of inflammation, ready to degranulate their contents and take care of business. So we've sketched some neutrophil first responders here, rushing to the scene of necrosis. We're talking 12 to 24 hours post-MI, remember. This is when you can start to see neutrophils in the area of infarction, breaking down those dead cells. Next, we're going to look at days 1 to 3 following the infarct. See the pattern of 3 suns down his tunic there? We're in between the full sun mask and 3 suns, between 1 and 3 days post-MI, in other words. During this time, the coagulative necrosis is extensive. Yeah, he's getting way in there. Also, neutrophils become even more abundant and continue to break down dead myocardial cells. Look closely at his shirt, by the way. On histology, you'll see all these little infiltrating blue cells in between the pale, dead myocytes. Yep, those are neutrophils rushing to the scene. If you haven't noticed, neutrophils and coagulation necrosis go together like George R.R. Martin and gratuitous sex scenes. And by that, I mean they go hand in hand. Grossly, the tissue becomes whitish tan and becomes paler each day. The most common complication during this time frame is early onset pericarditis. At Sketchy, a heart-shaped guitar often pericarditis. At Sketchy, a heart-shaped guitar often represents the heart. Sketchy, a heart-shaped guitar often represents the heart. The heart. A guitar case, then, represents the pericardium that encases the heart. See how the lining of the case is all red and inflamed looking? That means pericarditis. The typical clinical scenario goes something like this. Your patient is 3 days post-MI, and all of a sudden, he's got chest pain again. Uh-oh, is his heart reinfarcting? But the pain is sharp this time, doc, not the dull chest pressure I came in with. And the pain increases every time I swallow or take a deep breath. Yeah, it is a little better when I lean forward. How'd you know? Your patient is describing pleuritic chest pain. At Sketchy, that characteristic sharp pain that's worse on inspiration and better when leaning forward is symbolized by a razor-sharp tooth. And better when leaning forward is symbolized by a razor-sharp tooth necklace sitting against the chest. On cardiac exam, you might hear a pericardial friction rub as well. Hear that? It's a kind of squeaky grating sound caused by 2 inflamed layers of the pericardium rubbing against each other. Just imagine the friction caused by our unfortunate jester here as he skids toward his untimely demise. Pericarditis within the first few days following an MI is called early onset pericarditis, or peri-infarct pericarditis. It might pop up anywhere within that first week post-MI, usually after only a couple days. It's a result of the robust inflammatory response caused by the high concentration of neutrophils entering the affected tissue. Unlike viral or autoimmune pericarditis, this is not a diffuse inflammation that incorporates the entire pericardium. They love to emphasize that on test day, by the way. The inflammation overlies the area of infarction only. And that's why we placed that pericardial case right over the necrotic segment, tumbling into that necrotic catacomb. Don't worry, this looks worse than it really is. This type of pericarditis is generally short-lived and will remit with a short course of aspirin in 1 to 3 days tops. This looks worse than it really is. This type of pericarditis is generally short-lived and will remit with a short course of aspirin in 1 to 3 days, tops. All right, time to jump ahead in time a little. As they haul in a new batch of contestants, take a look at that cool half-moon shield held by the guard. Half a moon for half a month, or about 2 weeks. So we're looking at days 3 to 14 post-MI. This time period is dominated by an invasion of macrophages. They soon replace neutrophils as the predominant inflammatory cell visible microscopically. At Sketchy, those all-engulfing white blood cells are represented by macro cages, kind of like the cage here, hauling in our last contestant. Ugh, I really scraped the bottom of the Jester barrel this year. On histology, that means even more little blue cells scattered throughout the pale necrotic myocardial tissue. Just take a look at his shirt there to see what I mean. Aw, you see that old granny there, mourning over the wrongful imprisonment of her son? If the visual pun wasn't absurdly obvious enough, a granny with a tissue is a recurring symbol for granulation tissue. Wound healing and granulation tissue are discussed in much more detail in our inflammation unit. For now, all you need to know is that granulation tissue is a precursor to scar tissue. It's highly vascular and rife with activated fibroblasts. The accompanying neovascularization, by the way, is highlighted by that medievally fashionable neovascular dress she's got on. Granulation tissue generally begins to develop about 7 days after myocardial infarction and is most prominent on days 10 to 14. So remember, we're focusing on a time period of 3 to 14 days post-MI, as depicted by the half-month moon shield. Toward the beginning of this time span, at around day 3 to day 7, scar tissue really hasn't developed yet. Instead, coagulation necrosis persists, leukocytes are infiltrating, and macrophages are hard at work removing the debris left behind by all those neutrophils that crashed the party earlier. Remember them? The more tissue those macrophages gobble up, however, the weaker the myocardium gets. And it's at this point that the myocardium is most susceptible to rupture. Tissue rupture occurs in only 1 to 5% of MIs, but when it does happen, it can be fatal. The 3 types of rupture you'll most likely run into are ventricular free wall rupture, intraventricular septum rupture, and papillary muscle rupture. Let's start with papillary muscle rupture. The papillary muscles sit inside each ventricle, holding onto the chordae tendineae that secure the valve leaflets. It's kind of like the bottom of this instrument here, holding onto those heartstrings, when all of a sudden, it snaps right off. The clinical manifestations are immediate. Once those chordae tendineae get loose, severe mitral regurgitation develops. I mean, just look at our next contestant here, regurging all over himself as he goes through his usual pre-performance ritual of getting, medievally medicated. He's even got a flappy bicuspid hat on, depicting that dilated and insufficient mitral valve. On cardiac exam, you'll hear that hollow systolic blowing murmur characteristic of severe mitral regurg. You hear that? And remember, at Sketchy, whenever we want to highlight events that occur during systole, specifically, just look for that systolic spray. With mitral regurg, you've got blood shooting backwards into the pulmonary system, so your patient will present with acutely worsened dyspnea due to pulmonary edema. At this point, it's time to rush your patient back to the OR. Now, the specific papillary muscle involved here is the posteromedial papillary muscle of the left ventricle. It turns out that this papillary muscle is supplied solely by the posterior descending artery. No collateral circulation whatsoever. Remember the Kingslayer, reaching around the back with that right arm? In 90% of people, this posterior branch comes from the right coronary artery. Hey, stay with me. So take a look at that vascular gesture cap we've drawn in. The dangly thing on the right is meant to look like a right coronary artery, feeding a posterior descending artery. If any part of this gets occluded, that papillary muscle is more likely to become ischemic and rupture. Recall that in most cases, however, it's that left-sided circulation that's obstructed in the setting of MI. Remember that LAD lady? The left anterior descending artery is the most commonly involved artery. It's a branch of the left coronary. Hey, can we stay focused, please? Eyes over here. All right, take a look at the hat again. The LAD artery comes off the left coronary and shoots straight down the center of the heart. It's responsible for feeding the anterior 2/3 of the intraventricular septum. Occlude the LAD, and now you're more likely to cause septal rupture. It results in a ventricular septal defect, kind of like the hole ruptured in the septal tambourine. This results in immediate left-to-right shunting, audible on cardiac exam as a harsh, hollow systolic murmur. So, those murmur lines in the back should remind you that a systolic murmur can develop in the setting of either papillary muscle rupture or septal rupture. We won't see all those pulmonary symptoms this time, though. And remember, whenever we want to highlight events that occur during systole, like a systolic murmur, just look for that systolic spray. The 3rd type of rupture event to know is left ventricular free wall rupture, a serious and often lethal complication. See how the side of the heart lute is completely ruptured open? It's as serious as it looks, as these patients usually progress rapidly to heart failure and death. This complication is typically associated with obstruction of the left coronary artery or any of its major branches, as the entire anterior ventricular wall and apex is supplied by the system. So notice that we placed this whole lute rupture scene on the left side of that wacky coronary hat. Free wall rupture results in rapidly fatal hemopericardium and cardiac tamponade. All that blood collecting in the pericardial sac is depicted here, by this pericardial guitar case filling with wine as that cork flies by. Phew. The details of cardiac tamponade are covered more in depth later, but for now, I'll just quickly add that it presents clinically with muffled heart sounds, JVD, and systemic hypotension. It's not good. And that kind of sums up all these rupture events, really. Whether it's that papillary muscle rupturing, or that septum, or the entire ventricular wall, watch out for a precipitous onset of hemodynamic compromise characterized by hypotension and cardiogenic shock. Oh, you noticed our intimidating newcomer here? They call him the canine. He's here to remind you of the fibrotic scar tissue that begins to develop in this 3 to 14 day window we've been focusing on. After day 14, hence his position after that half-month moon shield, the debris that was removed by macrophages is largely replaced by collagen and fibrotic tissue. This scar tissue, it turns out, is even stronger than the surrounding myocardium. See how the cork that was causing all those rupture events just bounces right off of him? Doink! So once you get past that 2-week mark, your risk of any kind of tissue rupture diminishes. The scar tissue over the area of infarct will appear grayish-white grossly, and kind of dense and acellular under the microscope. Don't take this guy for some kind of big acellular softy, though. He can be pretty deadly when provoked. Because that scar tissue acts as a substrate for lethal arrhythmias. See that disguised jester there? Getting nabbed by the canine as he tries to escape? That quivering heart accordion is a recurring symbol for fatal ventricular arrhythmias, such as VTAC and VFib. These rhythm disturbances lead to zero cardiac output and sudden cardiac death. That death mask he's got on should remind you of... yeah, remember this guy? Within an hour of MI onset, electrical instability in the area of ischemic tissue can trigger VTAC or VFib, causing sudden cardiac death. It's the reason many patients die before ever reaching the hospital. So as you can see, sudden cardiac death can occur right away, or give it a couple weeks. Let that scar tissue start developing, and you have another whole reason for developing a fatal ventricular arrhythmia. There's also a complete loss of myocardial contractile function within that scarred area. Eventually, the surrounding viable myocardium just can't take the workload anymore. The chambers dilate due to eccentric hypertrophy, and the heart begins to fail. Hence a recurring floppy failing heart balloon, sinking to the ground there. This can take months to develop. Yep, we're talking many moons here. So let's finish up our discussion with a few of the more long-term complications of MI. And we'll start with what's called post-myocardial infarction syndrome. Yeah, because it's post-myocard. Okay, so it's not a very creative name. It's really a late-onset pericarditis. So let's sketch in another pericardial guitar case, shall we? Yep, that gesture is making a run for it. See how the lining of the case is all red and inflamed looking? That means pericarditis. And when I say late-onset pericarditis, I mean really late. Remember that other pericarditis syndrome that occurs around day 3, right over the necrotic segment of tissue? Well, this more delayed onset pericarditis occurs over a week later, months later even. It's also called Dressler syndrome. Many of the same clinical manifestations apply, including the onset of sharp chest pain worse with deep inspiration and improved by leaning forward. This is called pleuritic chest pain, and is yet again symbolized by that razor-sharp sharp-tooth necklace. Once again, listen for that pericardial friction rub on cardiac exam. Yup, there it is again. A kind of squeaky grating sound caused by those two inflamed layers of the pericardium rubbing against each other. Also, you see how inflammatory that red dress looks? Fever and leukocytosis are common findings as well. What's causing all this inflammation anyways?
Well, it turns out she's been spotted after all.
If you look closely at those arrows, you'll notice that they look somewhat immunoglobulin-y. Yep, those are IgG antibodies. And they're here to remind you that Dressler syndrome involves an autoimmune response against antigens exposed in that damaged myocardium. It affects the pericardium globally, rather than just locally over the area of infarct. Again, not a big deal. It usually resolves with NSAID therapy. Recall from our last sketch that ST elevation myocardial infarctions lead to transmural ischemia and necrosis. Well, when the infarct takes up the whole wall, so does the scar. And a few weeks post-MI, the entire wall thickness is gradually replaced with collagen and fibrotic tissue. Now, this scar tissue is pretty strong, but sometimes it gets a little too thin. This can lead to an aneurysm in the ventricular wall, usually about 4 to 8 weeks after the MI. It may look like a harmless outpouching, but a number of serious complications can develop. The aneurysm can be anywhere from 1 centimeter to 8 centimeters in diameter. And during systolic contraction, it kind of bulges outward and collects blood. This leads to progression of systolic heart failure as the stroke volume diminishes and an abnormal amount of volume is left in the chamber. So we've included a couple of our floppy heart failure balloons on top of the collapsing tent here. This stretched out, scarred myocardium also provides the perfect substrate for those fatal ventricular arrhythmias we keep mentioning. So keep that quivering ventricular accordion in mind as well. Remember, this aneurysm is made of tough scar tissue. It is not going to rupture. Instead, it acts as a big bag that collects blood. And in over 50% of cases, an organized thrombus forms inside. Sometimes little emboli break off, which can result in ischemic stroke or further MI. Just think of these thrombotic bird's nests that have developed in the wall here, sending down little ischemic bird poops.
And that's all for ischemic heart disease. It's a pretty broad term that encompasses a range of syndromes, both acute and chronic. But remember the singular theme and you'll never be steered wrong. That is, a mismatch between myocardial oxygen demand and coronary oxygen supply. And heed our sage advice.
When you play the game of ischemia, you win or you die.